So I would like to have the opportunity to present to you our initial experience with our solid organ transplant recipients during those first few weeks in March and early April. Feels like a long time ago, but certainly still quite pertinent. So going into this epidemic, we had, like many other infectious disease and providers, a number of questions that we needed to answer very quickly, but without any data. And specifically to transplant recipients due to their multiple comorbidities and chronic immunosuppression, a few more specific questions, including their infection rate in terms of prevalence and incidence as this epidemic was about to unfold on us, diagnostics, whether that nasopharyngeal PCR testing, whether, since it was already, there were issues with false negative results, would it be even worse with our patients? Their clinical presentation, usually immunocompromised patients have a more muted set of symptoms and vital signs, the disease severity, antiviral treatment, and in particular, immunosuppression management with someone with COVID-19, a lot of questions about what to do about that, and as well as outcomes. Obviously, these are a number of questions. Many of them remain unanswered, but we were hoping to at least help start with some baseline information here. As you know, the first case happened on March 1st. At our center, the first transplant case happened 12 days later on March 13th. And as of yesterday, we've had 191 patients. These are transplant recipients at our center alone, and within New York Presbyterian, it's a total 270 patients. A small cohort, but certainly a unique cohort of patients in terms of their baseline immunosuppression. We peaked, much like everyone else, somewhere between late March and the first few weeks of April, and at that time, we were admitting about 6 to 7 transplant cases a day. And for the transplant community, this was actually quite a lot and quite overwhelming because the patients just kept adding up, much like the rest of the patients. Had a profound impact on all of our outpatient and inpatient services. There was a near total hold on the transplants, including, as many of you have witnessed, a direct impact on our staff as well, getting directly affected by this in terms of coming down with infections. So this was not a benign course for transplant community here at MIP as either. So in that setting, we were at least able to produce some data for the transplant and for the community at large. And this was actually published a few weeks back. And this is what I'll be talking about for this symposium for the next several slides. So we were able to gather the first 90 patients that were diagnosed with SARS-CoV-2. It included both of our centers, Columbia and Cornell. All the patients who had a nasopharyngeal PCR that was tested positive. And this cohort essentially ran from our first patient on March 13th until April 3rd. And we had about a 14-day additional analysis. Overall, there was about a 20 to 21-day follow-up for the majority of the patients. So at least we're able to look at some more longer term outcomes. And just for the purposes of this paper, as you see, there's a lot of different classifications about in terms of disease severity. But for us, we just kept it a little bit on the simpler side. Mild disease meant outpatient management alone, moderate disease to general medical floor. And for severe disease, any patient that required mechanical ventilation or ICU admission, or obviously those who passed away. So those are sort of the disease severity classifications. And just jumping into the data, these are the baseline demographics for the entire cohort. And what we have here is all of the patients and then broken down, mild to moderate as well as severe disease. And what we were looking at sort of general differences between the disease severities, as well as sort of just trying to get some idea how different these patients were from the general population that we were seeing. Essentially, many things were about the same in terms of age. We definitely saw a difference between disease severity and age, particularly age over 60. Most of our patients were male as well, at least the ones who had some form of diagnosis and symptoms. Race and ethnicity breakdown. Our transplant population largely has a pretty diverse population, and given that where we are in terms of Washington Heights, so about 42% of our patients were of Hispanic ethnicity and 22% were African American. And then here you will see the organ transplant breakdown. As you can imagine, this was also an interesting question. Were lung transplants, for example, in particularly susceptible to this disease? What you can see here is this largely follows the breakdown in terms of numbers of transplants that we do in our overall transplant cohort. The large majority of these patients, as you can see, 51% were kidney recipients, and with decreasing numbers for the sort of more thoracic transplants and liver transplants. And as far as the disease breakdown between the organs, not much variation either, perhaps a little bit more lung transplants in the disease severity case, but obviously the numbers weren't that great to give any sort of statistical analysis. And then in terms of other baseline demographics, one of the questions that we had going into is what kind of transplant patients were going to be susceptible to COVID-19, relating to their time from transplantation. We were concerned that the more recent transplants would be far more susceptible. And it turns out that actually, on average, the time from transplant was about six and a half years or so. So basically, these were patients who were out in the community, much like the general population, and unfortunately getting infected either through household contacts or in their jobs. Very few patients were recently transplanted, as you can see. This highlights the number of comorbidities that transplant recipients already have at baseline, including hypertension, diabetes, CKD, not related to their kidney transplant status. Some patients actually were being treated for active cancer, and we use a pretty high threshold for BMI, but certainly a lot of obesity as well in our patients. We looked at baseline immunosuppression and what that meant in terms of disease severity. Calcineurin inhibitors, mycophenolate, and corticosteroids, as you know, generally are sort of the background for most of these patients. And as you can see, most of them were on some sort of the combination. And there was no difference necessarily in terms of what kind of immunosuppression regimen they were taking and disease severity either. There were some early reports that mycophenolate actually had some direct antiviral, anti-SARS-CoV-2 activity, but we certainly didn't see that here, it acting as a prophylactic agent for our patients. These are for the patients in terms of days from symptoms onset. Again, much like the general population, about 4 days. We did have some nosocomial transmission that was suspected. These are some patients who had been in the hospital for several weeks prior to March and acquire SARS-CoV-2 while in-house. We did have a number of false negative, or at least initially negative results, about 8% of our cohort, and then subsequently tested positive. So this was an interesting finding that sort of talked about the nasopharyngeal PCR. And then as far as presenting symptoms, mimicked largely the general population in terms of fevers, cough, myalgias, dyspnea, but also interestingly diarrhea. About a third of these patients had that. And this was not necessarily any different other than fever, which was interestingly perhaps a signal here that initial hypothermia or at least lack of fever might be more correlated with disease severity. So that was something that we postulated perhaps could be related to disease severity. And then hospitalized patients, as you can see, about 72% of our patients were hospitalized ultimately. The next few tables would be for those patients who were hospitalized. So 65 patients unfortunately had to be admitted. And for those, we had a little bit more complete data, including vital signs. And as you can see, much like what I said before, although 37.5 degrees Celsius versus 37.2, not necessarily clinically that significant, but certainly statistically a little bit of a signal that some patients who proceeded to severe disease were initially less febrile, so to speak, or at least lower temperatures. Our patients generally presented with some degree of tachypnea and hypoxia. As you can see, 94% was the lowest initial O2 set in the first 24 hours. And this was more pronounced with the patients who proceeded to severe disease, and this was statistically significant. We looked at initial laboratory markers, including white blood cell count, which was not necessarily that different from the general population, including hemoglobin and platelets. The NLR ratio, as you probably have heard before, this was something that we looked early on as perhaps a marker of disease severity. And perhaps we did see perhaps some trend that the NLR, the higher it is, the more sort of distorted the neutrophils and lymphocytes ratio are. And this was perhaps a little bit more on the distorted side, but nothing significant. And then in terms of chemistries, these patients already had a pretty significant baseline elevations in their creatinine, or at least some kidney dysfunction. Albumin, interestingly, and I think a number of reports have picked this up, that lower albumin is correlated with more disease severity, probably signaling some underlying disease, comorbidities, or perhaps an initial liver dysfunction already in terms of its synthetic function. We did not find any LFT differences in terms of AST and ALT or with total bilirubin. And then initial inflammatory markers, as you know, we gather a number of data on this for the majority of our patients. So the short of this is, although most of these, the majority of the cohort had already abnormal troponin, procalcitonin, C-reactive protein, D-dimer, ferritin, and including IL-6 levels, these were all in general elevated in our patients. The only one that really interestingly was different between the moderate disease and the severe disease was actually procalcitonin, which is somewhat surprising to us since this was normally thought as a bacterial marker and not viral marker. And these were patients' initial levels, so presumably they weren't coming in with secondary additional bacterial infections at that time. D-dimer, there was perhaps a signal here that there was more elevated, but the other numbers, including IL-6 levels, surprisingly was actually lower on the among severe patients versus those with moderate disease. And then in terms of what our interventions were, as a group, we decided early on that decreasing or holding anti-metabolites such as mycophenolate or azathioprine would be our main intervention in terms of management of immunosuppression. So the large majority of the patients had that done for them, and a few had some adjustment in their baseline steroids or calcineurin inhibitors. And there was no difference in terms of what that impacted in the moderate and severe disease, although the numbers didn't lend themselves for any further analysis. As the majority of the cohort at that time, most patients got hydroxychloroquine, and we still capture many of the patients who got concurrent azithromycin as well. And as many reports have now found, there's really no difference in terms of overall outcomes with that intervention. And then again, this was sort of small number of patients. And then immunomodulatory therapy, our lung transplant patients, our lung transplant team, so to speak, really did think about bolus corticosteroids for those patients as they were presenting with more severe symptoms. So we did have some patients who received that, whether with concurrent tocilizumab or not, it varied. And one patient actually did get IVIG as well, as thinking that that could be a useful intervention. And then in terms of outcomes, so you can see here the breakdown of the highest level respiratory support, at least at the end of the study period. So we had about a quarter of patients who remain on room air throughout their hospitalization, 30% of patients who remain on nasal cannula, and then the remainder were either on some higher levels of oxygen support or were requiring mechanical ventilation, as you can see here. And as you can see, all of the patients who were intubated were in the ICU, and some patients with non-rebreathers or BiPAPs also made it to the ICU, or some of these patients chose to be comfort care and did not proceed to ICU admission, but passed away while with a non-rebreather. So you can see here that 19 or 30% of our patients require an ICU admission, and those were all the ones who were intubated. And as far as mortality, this is where, what we were looking at in terms of our primary outcome for this study. So 10 patients passed away with around 20-day follow-up. Many of these patients remain hospitalized, so the numbers certainly have changed since then, but about 15% of our patients in-house passed away. And you can see the breakdown here for the organ transplants, with our heart transplant teams being most severely affected, although the numbers were quite low, followed by liver and lung, and then kidneys had the lower mortality rate. And as you can see, our mortality in the patients with severe disease, including ICU and or comfort care, reached 45%. So largely mimicking our general population who makes it to the ICU with really incredibly high rates of mortality. And for the in-hospital patients, about 15% mortality. The whole cohort, I put it down here, was about 11%. This has subsequently changed, as you can imagine, as patients who remain in the hospital eventually passed away. Our overall mortality rate at this point is about 14%. And about a third of these patients by the end of the study period had been discharged already, the majority of them with moderate disease, and only a few of them who had been in the ICU. So much greater rates of success for those with moderate disease. So we looked briefly, and we're still analyzing a lot of this data in terms of secondary complications. As you can imagine, we were really looking at secondary infections for these patients, and we have seen a number of ventilator-associated or even hospital-acquired pneumonias with pretty drug-resistant organisms at this point, including MRSA, ESBL, E. coli, and Klebsiella, including carbapenem-resistant organisms. We're seeing, unfortunately, a resurgence of those types of pathogens among our patients, in particular those who were intubated. A number of bloodstream infections, many of them catheter-related, but some of them not, including fungal bloodstream infections like candidemia. CMV reactivation was something that we were looking at. This already happens at baseline with our transplant recipients, and whether this hyperinflammatory process related to COVID-19 or with our interventions such as tocilizumab or bolus corticosteroids.
A two-minute warning, Marcus.
No problem with CMV reactivation. And the numbers are still coming in, but we've had basically in this cohort about 9 to 10% of the patients had some degree of CMV reactivation, and a few cases of aspergillus, in particular pulmonary aspergillosis as well. So in summary, obviously a lot still pending, but what we seem to gather from this initial cohort, actually, that our transplant recipients have very similar presentations to the general populations. Perhaps there are nuances there in terms of temperature or the lack of perhaps additional symptoms like cough and myalgias, but certainly generally very similar. We did seem to have a pretty high level of morbidity and mortality. However, as with all of these cohorts, it's an uncertain denominator because of test limitations. We're working on that with seroprevalence studies now so we can have a better idea. And then in comparison with other transplant cohorts that have been are sort of trickling into the literature or have been presented at our recent transplant conference, most of the other cohorts are presenting sort of higher rates of mortality, about 20 to 25%, with about the same time of sort of follow-up, 21 to 28 days. So our cohort sort of is a little bit below that. We've had significant secondary complications, much like the general population. And ultimately, the bigger questions for the transplant community is what is the correlation with chronic immunosuppression, or the baseline already elevated number of comorbidities that our population already has, and how those are impacting outcomes with our population. So those are all under investigation, including a number of other, as you can imagine, immune modulatory and immune investigations with this unique population. So I try to keep it short. Obviously, there's a number of other things, but I know that we had a little bit of a time limitation.
Thank you very much for that very interesting presentation. People can go to the participants button and raise your hands and I'll call on them, or they can use the question and answer button. Just to get things started off, two questions. One, the elevated creatinine seemed striking, assuming it's not just directly due to the immunosuppression. And did you notice dehydration of your incoming patients? And the second question is any insight into the high prevalence of heart disease? Was that something that was a pre-existing condition, or is that something that was acquired during the COVID-19 infection?
Yeah, excellent question. So the second question, these are mostly baseline. We were looking at baseline comorbidities. We did look at incidents of cardiac events such as myocarditis or arrhythmias. And, for this small population, we didn't really pick up an increased rate. There were basically 1 to 3 patients who seemed to have some degree of heart failure or myocarditis during their COVID-19 episodes. But most of those were baseline. And in terms of the creatinine, again, transplant patients already suffer from a degree of CKD that's pre-existing, but we did see a number of patients, in particular those with diarrhea, who came in dehydrated. And as you know, a number of these immunosuppressive regimens, or at least prophylactic agents, so things like tacrolimus and sulfamethoxazole, trimethoprim, some of these medications already have nephrotoxicity as adverse sort of secondary complications. So that potentially exacerbated that.
Yeah. Andrea, you have a question?
Yeah, I was wondering whether, so at least what we've heard from your colleagues in Italy is that there was a dramatic difference in outcome in the early days versus the later days where they adopted this combination of multiple therapeutic approaches. I was wondering whether you've seen similar things here as the treatment has adapted to the disease, and whether we see a lower level of death and severity of the disease, right now than we saw, say, 2 months ago.
Mm-hmm.
Marcus, while you're answering, can you unshare your screen so Rajiv can? Yeah.
Absolutely. Andrea, that's a burning question. We're preliminarily looking at that data, and I don't have anything to share with you, but certainly our impression is that this initial level of mortality has gone down for both the general population, but in particular for our transplant patients as well. Looking briefly last night, the sort of just the numbers in terms of mortality, those did seem to be overrepresented with the early admissions. But that requires a higher degree of sophistication in terms of the analysis than I was able to provide.